So I have a long name, Cirila Estela Vasquez Guzman, but I usually go by Stella or Doctora Guzman. I'm here in Oregon. Actually, it's kind of sunny, so I appreciate the sun trying to come out. And I've been in my position as assistant professor for 3 years now. Pretty early in my career, but pretty passionate about doing research in a way that's transformative and equitable, and really progressive. So I was so honored to be excited to be part of this community, because that way I can share a unique perspective. I always ask how many people have heard of medical sociology at the beginning. It's kind of hard for me to see everybody's faces, but if anyone has, put in the chat because I would love to know. But if not, I'm hoping to bring a new perspective today, and hopefully you can take that back to your chapters and kind of share it, because I think it's such an important lens to bring to the table that oftentimes gets missed. And then the other thing I'll mention in terms of my fun fact is that I am now 7 months pregnant. So my husband and I are expecting, and I'm super excited. It's been, yeah, I'm like a geriatric patient, they call me, but that's okay. It's never too late, and things are going really normal. So I'm really excited to be able to have the first grandchild on both sides. We've been together for 13 years. So I think it's time to move on to the next chapter. All right, so I have a couple of slides that I prepared to share with you today. I'll try to be as brief as possible to leave time for questions and answers. And let me know if you can't see it or if you can't hear me. All right, so let's just get started. These are actual pictures of actual participants from the research that I'm doing. But today, what I really want to talk about is what is medical sociology and how is that connected to cervical cancer. So medical sociologists, and I saw in the chat, a few people have heard of it, which is super exciting. And essentially, we like to emphasize socialization and using a structural lens to understand inequities. Now, what does that mean? So oftentimes we think of inequities as something, I think a lot of people have heard of it, especially with the Floyd situation and like all this 2020 COVID stuff. Like equity is starting to become more and more central in what we do and what you talk about. Usually we think of the image that I have to my left, which is, I like that image, but I don't really like it because it predetermines what the end goal is. The end goal there is to watch the baseball game or whatever game is playing. And then the next image, it kind of resonates with like, I have to lose something in order for someone to gain something. And I also don't like that perspective of equity because it's not true. It's not a zero-sum game. And then the next image that we oftentimes see is it kind of triggers this imagery of like, oh, we have to create something very specific and we have to tailor something very specific so that it works for that person or that community. And on the one hand, that's part of it, but it doesn't necessarily mean that every single community has to have something unique and different, right? So I'm a big fan of the last image, which is to the right. And that's mainly because it really does emphasize that it's not about equity is literally having missing rungs on your ladder, right? And no matter how hard you're working, no matter how hard you want something, for you to achieve just basic necessities, or for you to achieve your gift to the world, like we all have a gift to give to the world. Some people are just unable to give and achieve their maximum potential because they don't have access to like housing or transportation or English is their second language. There's a lot of different variations. And the end goal doesn't matter. Everybody has a unique end goal, right? Like it's not about the end goal being the same, but it's about you being able to have a path that is not as filled with discrimination or bias or assumptions or blind spots. So that's really what we talk about in socialization and sociology. And oftentimes, though, what happens is that we internalize the norms and ideologies that we're all actually starting from an equal playing field. And that's not true. And sometimes we forget that because we live in our own bubbles. And just hearing people introducing themselves earlier, we all have very busy lives. We all have very complicated lives. We're grandmothers, we're children, we're mothers, we're aunts, right? Like it's really hard for us to forget that our social reality is very unique and that the person next to us might be experiencing a completely different social reality. But that's what it means to have a structural lens. Like, what is it that shaped my social reality structurally compared to others? And how can we make sure that we're paying attention to those structures so that everyone has access to have their voice heard, everyone has access to realize their full potential. And in our case, everyone has access to be able to get their screening and preventive services for early detection of cervical cancer and other cancers, gynecological cancers. So now you kind of know a little bit about medical sociology and what I bring to the table. So let's apply that lens to cervical cancer. Let's apply that lens to my research. And then I want to end with some tools, because I don't want to just come and talk about, look what I'm doing. I want to leave you with some concrete tools that you can take to your own chapters. So part one is really talking about the inequities that I'm particularly concerned about. And I just wanted to, I know everybody said, but like, happy Cervical Cancer Awareness Month. It's January, so it's perfect timing that we're talking about this topic. I assume most people know this, but I just wanted to make sure, I don't want to make assumptions. Like I just said, you know, there's structures, and sometimes we know things and sometimes we don't. Cervical cancer is the fourth most common cancer globally for women, right? Which is pretty astonishing. And each country has these like metrics that we're trying to meet by 2030. We're really, 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 really far behind in general. For Latin America, and particularly, cervical cancer diagnosis in Salvador, Bolivia, and it's the second leading one in Mexico, Argentina, Colombia, and Ecuador. So there's something really happening uniquely in the Latin American, Caribbeans, and Latinas that's leading to like a strong leading cause of death. What and why cervical cancer? I assume a lot of people know what it is and where it is, because some people are survivors in this space, some people have friends who have done it. So I'm not going to spend time going over that. But the one thing that I do want to mention as a medical sociologist is that it's actually costing our system $3.2 billion just on like treatment of cervical cancer and diagnosis and all that kind of stuff. Imagine what we could be doing for that money in other ways, right? With education or prevention, right? Not just in the treatment of it. And why I say that is because we understand cervical cancer scientifically super well, like almost too well. Like we have 3 opportunities to diagnose it from stage 1, stage 2, stage 3, and then we even have 3 opportunities from pre-cervical cancer of stage 1 to stage 2, stage 3, SIN 1, 2, 3, right? We have so many opportunities to detect this early on, and yet women are still being detected too late, too close when it's progressing, that they have to lose their uterus or etc., right? And 90% of these deaths are completely preventable. And so as a medical sociologist, I'm like, what is happening? Because we have the technical, medical, and policy tools to eliminate it, and yet structurally or culturally, there's a lot of barriers for us to actually get there. And I was very happy to hear that some of you guys are already doing like education sessions and trying to like get the word out. For me, I'm very particularly interested in Latinas, as I mentioned earlier. We're more likely to get it, lower screening rates, and we're more likely to be less likely to be diagnosed. And older age Latinas. Our generation is rapidly aging, and we're forgetting that there's an international call right now to pay attention to cervical cancer and women above the age of 45. And even in Oregon, women over the age of 55 are less likely to get pap smears. What's happening is that women think, oh, like I'm outside my reproductive years, or I'm not having sex anymore, why should I get screened? That's actually not the case. More and more research is coming out that like actually we're less likely to get screened with aging, despite that over half of all the diagnoses occur over the age of 45. And there's this trend, there's graph here that I show that particularly among Hispanics, it's even worse with older women. So I'm really interested in the intersection of age and race. Now, how am I approaching this as a medical sociologist? So part 2, I'm really approaching this from thinking about what are the lived experiences of these women, right? I want to know their stories. And that's why we're so excited to hear people's willingness to share how they got involved in this organization. And my career goal is to really increase timely, culturally tailored, and trauma-informed screening and prevention, not just for Latinas, but for all underrepresented minorities too. I'm just starting with Latinas because it's containable, but I'm really passionate about Native Americans, African Americans, etc. Right? Like there's a lot of overlapping things and differences. I actually have a couple of colleagues that I partner with here at Oregon who do those different populations, and we're always constantly talking to each other. In this particular project, I only have 20 minutes. I have many projects, but I'm just going to highlight one. This one, I'm really interested in understanding the lived experiences of Latinas. As I mentioned, because I'm a medical sociologist, I'm interested in the social structural factors that are affecting their journey. And then more importantly, what do we do then to address those higher level factors? Because that's where people struggle, right? It's like first solution is like, let's just educate people. But what can we do beyond just education that addresses these social factors? So we have a paper already that's under review in R&R, talking about our multi-level recruitment strategies. Because I am Latina myself, I'm an immigrant myself, I come from the community, mixed status family, poor working class family myself. I'm the first person in my entire family to graduate high school, the first woman. So I've come a long way in my career, and I've grounded my research with community. And I'll just give a shout out to Selena because I know she's here. She's been super integral in our community advisory board. And my team has been really diverse and really innovative and creative in terms of like, how do we get our word out? How do we get people involved? We did focus on the Pacific Northwest, but I'm so happy to hear that Texas is here, Louisiana is here, Boston's here. Like, I would love to start to expand more nationally. And please, I hope people reach out to me afterwards. We did something called the DIPEX methodology. And the DIPEX methodology is, I will encourage you guys to look it up. It's origins at Oxford University, is now in 13 different countries. I love it because it's all about how do you do research with the community, but how do you do research not for the purposes of publication, but for the purposes of getting stories for other women to learn about those stories. So it's geared towards participant impact. And we're actually having our community event next month, and I'd love to extend an invite to that. But they share their stories. I don't make any assumptions about where to start. I have them start where they want to start, share what they want to share. Then I ask questions, and then I have them look directly to the camera because it's audio and video recorded to give a message. What do you want to say to doctors? What do you want them to know? What do you want to say to family members? What do you want them to know? And those, I would say, are the strongest, more powerful sections of the interview. I've traveled. We've had 51 in this study. 23 are cervical cancer survivors and 28 are pre-cervical cancer. I'm not a believer of having people come to me, and I'm not a believer of, I'm actually out in the community, traveling, going to their homes, meeting them where they are. And because of that, I got a really unique sample with like lower English proficiency, either currently or formerly undocumented, very, very, very little formal literacy or even education training. A few of them spoke Indigenous languages. And so these are the populations that are really hard to reach, but they were actually overrepresented in my sample. And I think it's because I was willing to like go out, and I did very creative outreach. And just to like wrap us up, because I know I'm almost out of time, but my community advisory board member, as I mentioned, has been really intimately involved with the coding, with the interview questions. If anybody's interested in being involved, I just got a new grant. Please reach out. I would love, I'm always looking for ways to partner. Our code book is very complicated. There's so many themes that are emerging and so many different categories that we're looking at in both of the databases. 3 things I'll just point out today in terms of for you to share back to your community or back to your members in each chapters is 3 things. Number 1, the degree of isolation that is present is significant. A lot of women do not share what they're going through with their family or their friends, ever. Not even their children, maybe their partners. That is if their partners stay around after going through this kind of experience. And I think the healthcare system is doing a big disservice by not thinking about how we can better support women who are going through this, especially because it remains a highly stigmatized and shameful kind of cancer. It's not easy to talk about. And number 2, transportation. A lot of women are taking the bus after they get a LEEP procedure or in order to go to the doctor by themselves. And that just breaks my heart, right? How can the healthcare system provide better transportation, Uber, or I'll tell them, bring a friend to like make sure you're not alone, right? And then the last thing is empowerment. It's been fascinating to see a lot of women who get care at community healthcare centers all of a sudden get sent to like a big hospital or triage hospital, or they get an oncologist that's assigned to them so they have better continuity of care. These shifts in how they view and experience healthcare encounters has been profound in many of them. They're much, much more willing to be open now, share everything they feel. And this idea of like, how can I be more proactive and engaging with my provider and require and even ask for second opinion or ask for a new provider if needed. That advocacy piece, I think, is oftentimes something that patients don't think they have. And then after going through an experience like this, it's the number 1 recommendation we hear, right? So 3 messages is make time for yourself. Before I used to have a very clean house, and now I just make sure to take care of myself. We have all these social, cultural constructs of what it means to be quote unquote a successful woman, or quote unquote a woman who has it all, or someone who's doing it all. And oftentimes when it comes to your health, you are number one. And it's a hard lesson to kind of swallow or know, but we heard that over and over from women. Number two, know your body. And it's not your fault, right? Just because you didn't go to the elementary school or high school or have college education, there should be no shame for us not knowing the name of our parts. Our our reproductive system is so complicated, but it was amazing how many women just say down there, or down, in that area, or just the uterus area. Like, no, there's the uterus, there's the cervix, there's fallopian, there's ovarian, there's a lot of different things that can go wrong in our reproductive system. And unfortunately, the education system has been done us a disservice in not really teaching us how complicated that one piece of our body is. And finally, just sharing, right? Communicating a lot more and earlier on, not just with your providers, but with family and with friends. And that goes going back to a medical sociology perspective. When women tell their partners, hey, I'm bleeding a lot, I think it's part of menopause, that's a big myth out there, right? Bleeding a lot is not a part of menopause. And when partners are not also educated about women's bodies, that's also a problem, right? Because partners could be intervening and helping their partners, like, actually, that's not a symptom of menopause. Please go get checked. Or thank you for sharing, how often is it? Where is it? Instead of just saying like, oh, this is normal, this is normal. Because we know cervical cancer is a silent killer, right? It's not something that you have symptoms of. And yet we live in a culture, in a society where you go to the doctor when you feel symptoms, right? You go to the doctor when you feel sick. You go to the doctor when you don't feel well. And in fact, we're trying to change that. And how do we change our healthcare system that is more proactive and more preventative and screening oriented, not just when you have a challenge? And of course, that's tied with insurance problems and fear of like employment, etc. So this is the model that I'm working with, and I'm happy to share these slides. So please share it with everyone here. I love this multi-level influences of the cancer continuum. When we think of the cervical cancer phenomenon, even though I captured individual stories, which is that circle in the middle, I'm really trying to look at what are the other domains that we can intervene to support that individual. So going back to my equity image that I started my talk with, it's not the individual's responsibility. And if you get anything from my talk today, as a sociologist, it breaks my heart when women continue to internalize or blame themselves because they weren't educated, or they didn't seek care access right away, or they didn't share XYZ, right? It's our systems and our culture that has created a context in which where we delay care. We think we got to do it all. Work is more important, right? So it's a much more larger structural cultural problem. And those are the issues that I think we need to talk about in order to really make a difference when it comes to screening and prevention of cervical cancer. So in my last couple minutes, I'm going to close with just talking about some equity tools for you to take with. One is, it's not an us versus a we. If you've heard of CBPR, community-based participatory research, that's great. I would love for you all to feel and empowered to be researchers yourself. I heard one person went to medical school, which is great. Congratulations on graduating. I think there's unfortunately this divide in our society where if you're educated and you have education, you're up here, and someone who didn't, I don't know how to engage. I don't know how to be part of this. And that's another sociological misconception, because people, even if they didn't have the opportunity to go to college or go to school, and keyword opportunity, it's not about them working hard or making bad choices, right? It's oftentimes a structural lack of opportunity to go to school. They're very, very smart. My mother has a third grade education, and yes, she was able to mobilize a significant amount as an immigrant here in the United States. And she's very well savvy when it comes to healthcare systems. And so there's need to be more voice of community and lived experiences in the research space. And there need to be more partnerships between research and community members, which is what I'm really trying to do in this project. But I'm hoping that happens in others. And a few strategies, just to give a couple ideas off the top of my head for you and your chapters, is why don't you highlight an article, maybe every time you meet, right? Or like, why don't you bring in a perspective piece that's out there in academia that you can respond to? I would be more than happy to share some resources that could ignite discussions, right? Because sometimes the research world is so separated, unfortunately, and that's why it takes 10 to 20 years for whatever findings we have to actually be disseminated into the everyday world. I developed an infographic because even though I interviewed women with cervical cancer and pre-cervical cancer, none of them, very, very few of them were able to tell me what it actually was. Where does it come from? Where does it originate? What are the causes of it? And that to me is a disservice. How can we have a whole healthcare system around cervical cancer and the basic educations of the origins or how it happens are still lacking, right? And then when we uplift sociology, the second main message that I want you to take away is that what we're trying to do is reframe personal struggles as societal ills. I would love to build a community of support and inclusion and feeling seen because people are not alone. And our society does a really good job of separating and fragmenting us. You know, people are looking at the tail of the elephant or the trunk of the elephant or the eye of the elephant, and they don't talk to each other. Or we live in our bubble and it's hard or scary for us to jump in a different domain because we don't know who's there, what's there. Or we're so busy with our lives and there's so much pressure, water keeping us in our bubble that we don't actually tend to go out and read about other disciplines or other cancers, where there's some similar trends or similar parallel kind of discussions that could happen. And so my last slide is network, 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 just showing up here and just hearing your stories already about like I got involved, or Lisa was the person that got me involved. It is already a huge win, right? Partnering with others is what allows us to kind of move forward, and not saying that we're okay. And thank you for the person who spoke first, saying that you're having a lot of challenges. We're all having a lot of challenges, and when we live in a society where we keep saying I'm okay, I'm okay, like nothing changes. We're not okay, right? There's a lot of stuff happening immigration wise, the fires in LA right now, right? Like, and we just pretend to be okay. Um, and so it's okay to not be okay. And I think it's more important for us to show our vulnerabilities and kind of show that the system upholds something that is not working for them or for us. And then establish a growth mindset. I have a lot to learn. I'm always learning constantly. And I'm failing forward as well. If I do something wrong, I want the next generation to know, right? And then finally, undo the need to fit in. We're constantly pressured to fit in. And I think by doing the same thing we've done for the past 10, 20, 30 decades, the research is there. It's well established, cervical cancer, and yet we continue to find the same numbers. We continue to find the same disparities. We need different interventions, more innovative solutions, and not being afraid to chart the unknown. So I was really excited to be invited here to be able to share that perspective with you. I have a long road ahead of me, but I'm very open to having ongoing discussions, very open to collaboration. I put a QR code here if you want to give me feedback on the talk. I forgot to put my email on here, I realized, but I can show it right away. And I just realized that I was talking to my other camera when I should have been talking to you, which is right here. My apologies. So I'm going to stop there. And let's open it for Q&A because I would love to get some invoice and perspective. Let me end the sharing.
Wow, Dr. Guzman, that was amazing. Thank you so much. I feel like I could have listened to you talk for a whole nother hour. There's so much there. And I'm grateful to have you as part of our resource community now. And leaders, she is part of our network now. So if there's ever any questions you have or resources we can use that she has, please don't hesitate to reach out to me or her and we'll coordinate that. If you have a question for Dr. Guzman, you can drop it in the chat. You can raise your hand. Those are all options. I really liked your slideshow. I will be sharing that with the group afterwards.
Yes, please do. And let me put my email in the chat right now. And I see you have a hand up. Is that a question?
I do.
Okay.
So yeah. Thank you so much, Dr. Guzman. So I don't know if you heard my presentation at the very beginning about the history of ASHA at NCCC. I'm very interested in what you're talking about. Do you have a video? Do you have a tool that ASHA could promote in Spanish
I do.
that is directed to the public?
Yes, that infographic that I showed you, we did in both Spanish and English.
Okay.
So I'm more than happy to share that with you.
That infographic is really dense.
It is really dense. And then the other thing that I have Well, it's a video. We're working on translating it to Spanish right now. But it's kind of like
I wrote
highlighting
down
the
to
project.
translate your talk, but I was like, that's not really a good talk for the public. There are pieces that are great for the public, but
I'm happy to do a similar version that's more in for the public and in Spanish and English. I'm more than happy to work with you to do that
that
too.
would be great. This is such a challenge and a frustration that we are not further, as you said so clearly, we're not further ahead on something that really should not be the problem that it is still. Yeah.
Right. And I think it's because we continue to be in this individual perspective, right? And then like now we're being pushed to think more culturally and structurally. And unfortunately, medical sociologists, we like to stay in our bubble. We're very Ivy Tower theoretical researchers, but there's more and more people like me who are starting to be in School of Medicine departments,
On the
starting to
street.
be in more, yeah, exactly, industry,
Yeah.
right? We're starting to branch out and people are starting to know that we exist.
Yeah. This is so important. Thank you so much.
Yes, thank you so much. I appreciate that. And then Gail, I saw your comment about the perspective and old nursing perspective.
Oh,
Nursing
that was
professor.
just to you guys.
Oh, okay.
So anyway, what I did want to say is that I'm so glad you're working on this. The last time I was at AACR, the American Association of Cancer Researchers, I had a poster, and multiple of the bench researchers came to the survivor group that we were in and said that we were the first survivors they ever met. So I thought,
Wow.
it was really, really quite moving to hear that and to know that they work in isolation as well as the patients being in isolation. So that was just my comment.
Yes, that's a great comment, Gail. I know it's crazy how, well, for me, the best analogy that I use is the eye. It's this tiny little part of the body, and yet we have an expert that does the front of the eye. We have an expert that does the back of the eye, the cornea. We have an expert that does, because my mom has eye trouble, and we go to the eye doctors, and I'm like, how is it possible that you have 4 different eye doctors for this small part of your body? And that's how hyper specialized our medical system has become. And on the one hand, it's great, right? Because we need that for really rare conditions. And on the other hand, it's unfortunate because they can't really talk to each other. And so when we think about the reproductive system of as women, right, in our organs, it's the same thing that's happening. And so we need a lot more cohesion and just comprehensive care, and not just for the patient's sake, but for providers' sake too, because it's starting to become just impossible to be able to do it all. And for me, patients' voices and experiences is the number one. Like we should be centralizing those who are affected most by the situation. Thank you, Gail. Yes, Alina. Nice to see you.
So great to see you. I would just like to share with everyone that Dr. Guzman and I, for the 2nd year now, have hosted in Vancouver, Washington, which is right across from Oregon. We're essentially all in one Washington and Oregon medical community in Southwest Washington. We host a social where we bring in other medical students, members of Dr. Guzman's team. This year I made several calls out to our local legislators that work in the Latina community. We are really working hard to bring voice to women on a soft level, but women that are leaders with leadership skills to share with others that ultimately we can have that common voice. And the other thing is if anybody wants any other information on Dr. Guzman, she's also on my chapter page. And we work intimately together between Washington and Oregon, our favorite Pacific Northwest.
We do. Yes. Thank you for bringing that up. I appreciate that. And I'm more than happy to share. I know our community event is coming up next week, Selena. So I'm excited for that in person, and we can, share what we find and what we found with this community as well. Denise, yes.
Hi, Dr. Guzman. Thank you so much for your amazing presentation. I'm originally from Jamaica. You can probably hear my accent. And I'm a retired professor. I taught nurse practitioner students. So I got excited when you were talking about academia and everything that you were doing, because I conducted a lot of research before I retired.
Nice.
I was listening to you talking about how important it is to include the spouses. And I work as a nurse practitioner as well. And I incorporated the spouses, although usually in the GYN clinic, it's norm and it's all females. So there are so many limitations within the actual healthcare system that's impacting everything. And I can see where, as a researcher, you can actually collaborate with other healthcare professionals or people in other spaces, such as those who are in like informatics, when you think about the election
Mm-hmm.
and how you can centralize everything and have things like medical homes and healthcare systems. So you're doing some amazing things, and I know that we'll be hearing a lot about you and from you in the future. So thank you so much for what you've shared with us and how you've ignited us. I liked what you said about sharing articles when we meet up. So that is something that I'll definitely plan to incorporate when I'm in the community talking to others.
Wonderful. And maybe I can send a handful of, Rena, I can send you a handful of articles that I think are really great. And academia is starting to move more and more towards like writing not so jargony and not so complicated, which is good, because then we can actually share it more and more with community members. And the firewall is oftentimes a problem, but I can get access through my library for a couple of them and then share it so that the network can have access to a few as well. But Denise, it sounds like you have access too. But there's another structural limitation, right? Is the open access versus the closed, having to have an association with the university. And then there's one more thing that you said that just reminded me of is, getting involved with your spouses, but it's also disheartening that a whole generation of women have had cervical cancer and pre-cervical cancer. And because they don't know enough about it or can talk about it, they're not able to educate their children or grandchildren on it. And so we're already seeing a missed opportunity for multi-generational influences even as well. And so I think the healthcare system doesn't quite recognize that when they treat an individual, it's not just them treating an individual. They could potentially be treating that individual and the entire family, entire next generation, if they're able to do a really good job of communicating exactly what's happening, to be on the same page. And when they don't do that, it's a missed opportunity. And so the next generation, again, are not as aware or not as informed. And this generation particularly didn't have access to HPV vaccination, right? Like that's something that my generation barely got access to when I was growing up. And so there's a huge multi-generational kind of ripple effects that happens as well when we don't think about beyond the individual. So thank you, Denise, for bringing that up.
You're welcome. And as you said that, I think sometimes as chapter leaders, we don't think we're doing much. And people tend to think educate, educate, educate. But education is such an important piece because, like you just said, the elderly people probably know about it, but the younger generation don't know. And we have such a diverse group of chapter leaders here who can actually get to different groups of people. And there are a lot of generally speaking, communities, we meet together. I know in Louisiana, everybody gather over food and there are multi-generations, so we can use those opportunities to share information with each other. I mean, we gossip about all kinds of stuff, gossip about things that will help our bodies to do better.
Yeah, we do the same. We do the same. It's so important just to let down, get real, and enjoy one another, and just get over the rigidity of should we talk about this or not that, or just kind of giggle and laugh and enjoy nature and enjoy good food and commune again.
Yeah.
Exactly. Yep. And how to think of education as not just individual facts, but education of the entire system. And that's where I'm trying to bring we're writing a new grant right now with my colleague, Amanda, who does work with Native Americans. And we're reframing education in terms of a structural education. Because oftentimes we don't talk to communities. It's like, it's not your fault, right? Like the system is just not set up to teach you this. So, but like bringing in that systemic perspective and bringing in how the structure and the culture is set up in a way where the education is not just like, oh, how do you not know about HPV vaccination? How do you not know about the HPV, 16, 18 and all that kind of stuff? It's structured. Yeah. So thank you both. And Selena, big shout out to you. Thank you for suggesting my name to this community. I'm so excited to be here. I know I've taken plenty of time already. I would love to continue the conversation. And I'll hand it back to, Brina or someone else, because I know we have, I think, another keynote speaker. So
Yes.
gracias.
Thank you so much. That was really wonderful. And as you guys can see, her contact is in the chat. This is not the last time we will hear or see Dr. Guzman. So thank you so much for your time.
Yeah. And Lynn, I
And-
saw your hand raised, but just put it in the chat and I'm happy to answer whatever comment or question you had. So
That
That was
sounds
me
great.
actually trying to send you this.
oh, thank you.
Okay.
Thank you so much.
Thank you so
And-
much.
And to pick